Thank you, Dr. Harari. As you can see, I've dyed my hair back to its natural color at this point, so I'll have to thank my wife for forwarding that photo. Again, my name is Stephen Rosenberg, and today we're going to be talking about MRI-guided radiation, motion management, and much more in GI cancers, and thank you so much for coming this morning. I have no conflicts of interest for this talk. So this is a little bit of an outline of where we're going today. We're going to talk about the motion of normal organs and tumors and how that plays into MRI-guided treatment. A little bit onto the delivery and planning of MRI-guided radiation. We'll talk about motion management in action, our multi-institutional experience of MRI-guided liver SBRT that we've developed, and real-time adaptation of radiation with MRI guidance. This is a form of precision medicine that we'll go into. And the assessment of tumor response during radiation, a new area we can look at with daily MRI guidance for patients. And a little bit about future directions as well. So life is in motion, as we all know, and our bodies are in motion. Accounting for tumor and normal tissue motion remains an ongoing challenge for radiation. And so I give you some examples in the GI tract here in this table I created. This is looking at the magnitude of motion. You can see with the liver, you can get up to 2 centimeters of motion in the superior and inferior direction. In the esophagus, as you can see up there, also up to 1.5 centimeters of motion. Now, I will say this is more for distal esophageal tumors, but much more than many people would ever think of. Pancreas also, a magnitude of almost 2 centimeters of motion. So accounting for this remains an ongoing challenge while we're delivering radiation treatment. This is not the only area of the body, of course. Lung cancers also have significant motion depending on the part of the body. And so how we deal with this is an important part of patients undergoing radiation treatment. And so how have we dealt with this? There's been multiple systems to help address motion management and daily setup. One of the ones that we've used in the past is abdominal compression. That can limit the respiratory amplitude of patients' motion, therefore limiting tumor motion. That actually involves usually putting a compression plate on the abdomen. Spirometric breathing control uses spirometry to actually see if we can use that to help gate our treatment using flow loops and other things like that. Fiducial placement is another way of managing motion. An example of that is on the right of your screen. That involves an invasive procedure, placing fiducials either in the tumor itself or other nearby organs. And Vision RT is a newer way of managing motion. This actually uses the external contour of a patient and try to correlate that with motion that's happening inside the body. I will say, though, when we think about that, what happens on the outside doesn't always reflect what's happening on the inside. And of course, we're going to talk and focus our way of managing motion with MRI guidance. And so how do we deliver MRI-guided radiation at the University of Wisconsin? We use a machine called ViewRay. A computer-generated image is on the left of that, the left of your screen to kind of visualize the machine. It's an open, split, solenoid 0.35 Tesla MRI scanner combined with 3 coplanar cobalt sources. And what you can see here is a schematic on the right of your screen. You can see the treatment gantry actually split amongst the treatment gantry that's housed right in the middle that actually houses those 3 cobalt sources. And that treatment gantry is able to rotate as a patient is in there to deliver radiation. This is how a patient looks, actually, in terms of their setup of heading into the machine. You can see the coils that we often place on the front and on the back of the patient. They usually go in with arms up. As they head into the bore, we can actually talk to them, and they can talk to us. So we can provide coaching and feedback in real time about their breathing and how to other ways help manage motion. For these patients, there's no other motion management system in place. We're not using abdominal compression or any other way of trying to limit their breathing. So when patients go into the machine, the first scan they get is called a TRUFI sequence, which stands for True Fast Imaging. It's a mixture of a T2, T1 weighted image. It's been adapted from cardiac imaging. An example of that is on the right of your screen. And you can see I've outlined the tumor there in red for you. You can see that's lit up nice and bright in the liver with some surrounding isodose lines as well for a patient's radiation plan. Once we have this 3D image, we then pick a slice from the axial scan and actually do our tracking in the sagittal plane, known as a cine. It's a real-time tracking, and we'll really dive into what that means going forward. We typically use what's called a PTV, a planning tumor volume, as a structure, as a boundary for gating during treatment. So we take our tumor and put an expansion around it of anywhere from 2 to 5 millimeters, and that becomes our gating structure for actually triggering treatment, which again we'll show you some examples of as we move forward. Now, I don't want to get too much into the physics behind MRI-guided radiation treatment, but it's worth at least noting a few important things. We use a Monte Carlo treatment planning algorithm that takes into account the electron return effect. Well, what does that really mean? Is that we all remember from basic physics as electrons move through a magnetic field, they bend relative to the magnetic field in strength, and so our treatment planning algorithm can take that into account. Optimization and dose calculation takes minutes, and that's really important because we're going to talk about adaptive radiotherapy. It really is an important fact that we have some speed associated with this as well. Treatment with this type of treatment is step and shoot, which means as the gantry is in one position, it delivers the radiation. As it rotates to the next position, it then delivers the radiation. It doesn't deliver the radiation while it's rotating. Those are called arcs. Typically, with this type of radiation, we're delivering 10 to 12 beams per plan for a liver SBRT treatment. Again, a plan of radiation is seen on the right of your screen with that trophy sequence. So this is the real-time cine MRI on the right of your screen. I've outlined some normal organs for you: the heart, distal stomach in green, some bowel loops. You can see the tumor. This is actually a distal esophageal tumor, and that gating structure that I mentioned before, which is an expansion off of our tumor. And so as the patient's breathing, we acquire approximately 4 frames per second for this patient. The radiation beam only turns on when the tumor is within the gating structure. And usually we can set that threshold, and usually we're setting it between 90 to 95% of the tumor being in the proper position. And as you can see, there's a lot of motion associated both with the patient breathing in this setting and with cardiac motion. As the patient takes an appropriate breath in and the tumor ends up in the correct position, the radiation turns on, and you can still see there's been, say, some separation of the tumor from where the heart was and some other structures as well. And just to give a sense of motion, this is where the tumor was located, and this is where it ended up. And this gives you a sense of how much motion there really can be, even for these distal esophageal tumors. And the radiation will remain on until they can't hold their breath anymore, they let that out, and we have less than 90 to 95% of the tumor within the proper position. That's just a little bit of the background about how we sim patients and develop their radiation plan. Let's talk about our multi-institutional experience of MRI-guided liver SBRT. This was in conjunction with WashU in St. Louis and UCLA. They've been very supportive and helpful in putting together this project. We've been lucky enough to kind of lead this here at the University of Wisconsin. And this is currently submitted for publication, but I'm happy to kind of share some of this early data with you now. So a lot of this data was prospectively actually collected, but we really looked back retrospectively. Patients with 1 to 3 metastatic liver lesions or a primary liver tumor were eligible for this analysis. No strict cutoff on lesion size was placed. These were patients where surgery was not an option. Most of them had some sort of previous both local and systemic therapy. Typically, patients underwent SBRT with MRI guidance, 50 gray in 5 fractions. However, other fractionation schemes were allowed. And so we defined liver SBRT as greater than 30 gray or greater than 6 gray per fraction. We were really interested in analyzing freedom from local progression, overall survival, and toxicity for this cohort. In terms of delivering the liver SBRT, patients with metastatic lesions typically receive contrast with each simulation, known as EAVIST, and we'll show you why that's important in a minute or two. Radiation treatment wasn't done universally the same at all institutions, in that at the University of Wisconsin and at UCLA, we treated with a max expiratory breath hold, which again I'll show you. At WashU in St. Louis, they tended to treat with an expiratory breath hold. Now, the time in the treatment room was typically 40 to 60 minutes to deliver this treatment, but the actual treatment time usually was around the order of 20 to 30 minutes. So that extra time is usually taken to actually get the patient set up in the room, acquire images, and make sure the patient is set to begin their radiation treatment. So this is an example of a cine for one of our liver SBRT patients. What you'll notice here is that the liver is nice and bright. That's because of that contrast agent EAVIST that I mentioned that's taken up by normal hepatocytes, making the liver bright. Of course, the metastatic lesion, in this case a colorectal met, doesn't have hepatocytes, so it doesn't take that up, making the tumor nice and bright and easy to track. That gating structure that I mentioned is our red component that you see here, and as the patient's taking some deep breaths, they almost breathe in a little too much, in real time, when we can talk to the patient, let them know, let a little bit of air out. And as they do that, the tumor will fall into the correct position and the radiation will turn on. And so this is this advantage of gating where we can see the tumor, make sure it's in the proper position, and actually give real-time feedback to patients. And this is a very unique thing to be able to do. So this is our population that we treated. We treated 26 patients in this cohort with a median age of 70, wide age range from 30 to 90. We did have a 90-year-old patient treated here at the University of Wisconsin who tolerated it very well. The vast majority of patients were male. The majority of patients had colorectal metastasis. After colorectal was primary liver tumors, hepatocellular carcinoma. We treated some combinations of lung, cholangio, pancreatic tumors, and a mix of other tumors as well. In terms of our median PTV size, it was around 98 cc's. Our median dose of the PTV, as I mentioned, was 50 gray in 5 fractions of 10 gray per fraction. But as you can see there is a range from 30 to 60 gray in total and anywhere from 6 to 12 gray per fraction. When we're planning our radiation, one of the things we try and do is keep a low mean liver dose, which means decreasing the dose to the rest of the liver. And we usually try to keep that less than 13 to 15 gray. Here, the liver median dose was 12.7. However, I would note that at one of our sister institutions, one of the liver means got all the way up to 22 gray almost, and this was at the discretion of the treating physician, balancing risks and benefits. In terms of toxicity, the toxicity was minimal in this cohort. There was 2 grade 3 toxicities, 1 hilar stricture, and 1 patient developed portal hypertension. There were no grade 4 or 5 toxicities seen in this cohort. A little bit about our results so far. And so our median follow-up at this time is 8 months. We only included patients in the analysis in the freedom from local progression and overall survival who had greater than 3 months of follow-up, which was 24 patients in total. And at our median follow-up, our freedom from local progression was 96%. We only had 3 local failures out of our 24 patients. In terms of overall survival at that median follow-up, it was approximately 89%. We did have approximately 5 deaths on treatment. Out of those 5 deaths, only 1 of the 5 patients that died had a local or marginal recurrence. The other 4 patients had regional and or distant progression of disease. And I think that has important implications about talking about both the importance of local control for patients and for systemic agents to control distant disease. In terms of local control by tumor histology, we had no failures for patients who had hepatocellular carcinoma. Typically, colorectal adenocarcinomas have a slightly lower local control rate than some other histologies, but still on the relatively good end, around 71%. And those patients that didn't have hepatocellular carcinoma or colorectal carcinoma, we grouped all those other histologies together, and the local control there was approximately 91%. When we actually did a chi-square analysis of comparing colorectal versus non-colorectal histologies, it trended towards statistical significance for decreased local control, but didn't quite reach there with a p-value of 0.13. We had 15 patients that had a Child's Pugh score available before and after treatment. Just to remind everybody, Child's Pugh score gives a sense of liver function for patients. All 15 patients that had a score before and after available all started out with Child's Pugh A. And we had 2 patients that did have a drop in Child's Pugh score. One of those patients, the top patient that went from an A to a B, had 4 taste procedures in total before going on to liver SBRT. The other patient that went from an A to a C had a very large volume that was treated and a high liver mean dose. If you remember, I showed you that range of doses to the liver, and that was that one patient that had a liver mean of 22 gray. It's not too surprising that they had a significant drop in liver function. Overall, for patients that had appropriate follow-up with greater than 3 months, our freedom from local progression was 88%. 21 out of the 24 patients had no signs of local recurrence. There was a good local control rate of colorectal metastasis at 71%, but that's still slightly lower than some of the other tumor histologies. The overall survival at the median follow-up was 89%. As I mentioned, only 1 of the 5 deaths had a local recurrence. And so this, to me, stresses the importance of both local and systemic control for our patients. And again, toxicity was minimal with only 2 patients with grade 3 toxicity, and there were no patients with grade 4 or 5 toxicity seen in this treatment cohort. So what are some of the limitations of this study? It's a small, heterogeneous group of patients. Our follow-up at this point is only 8 months, so of course we're going to continue to follow these patients going forward to see how they continue to do. So MRI-guided radiotherapy, though, at this point appears safe, but is it consistent with the literature? Are we meeting previous benchmarks? And so I think one of the ways to compare this is from an experience from the University of Michigan, from Liu et al., that looked at 62 patients with 106 different lesions treated within the liver with either 3 or 5 fractions. Their motion management system there was ABC, which stands for active breathing control. This is basically a form of spirometry that I mentioned a little earlier in the talk. And they were interested in analyzing both that freedom from local progression and overall survival, just as we were in our study. So from their study, the freedom from local progression at 2 years was approximately 82%. Their 1 year freedom from local progression was 93%. If you remember from our data, our freedom from local progression at 8 months was approximately 96%. So similar outcomes as we see here. In terms of tumor histology, they broke things down as well by HCC and colorectal metastasis. Their freedom from local progression with HCC was 93%, and colorectal metastasis 67%. So their data looks pretty similar to ours in terms of local control rates. And so I think the questions come is that local control rates seem consistent with the literature. Well, that's wonderful. But what can we do to make things better? How can we actually improve outcomes even further for these patients? And the only way to do that, in my mind, is to really look closely and scrutinize both our treatments and our outcomes for this patient population. So with that, let's actually analyze one of our patients that failed, one of our local recurrence patients. So this is one of our patients that have colorectal metastasis with a local failure. This is their diagnostic MRI scan. I've outlined the tumor for you here in red. You can see in the coronal view in the liver and the axial view. And let's talk a little bit about their radiation plan. So this is their ViewRay scan shown in the coronal plane. I've outlined for you again the liver here in blue, the target, which is the tumor with a margin on it here in red. You can almost see the tumor with this kind of dumbbell shape to it. And I want you to pay close attention to the nearby stomach and bowel for this patient. So actually, as we plan this patient's radiation treatment, one of the things that we do is we try to limit toxicity. Well, how do we do that? We try and make sure that nearby normal organs aren't getting high doses of radiation. So for this patient, one of the things that we're worried about is the dose to bowel or stomach that's also nearby. And one of the constraints that we think of normal bowel or stomach with liver SBRT is keeping the dose of the bowel of 30 gray to very small, less than 0.5 cc's. The 30 gray isodose line here is outlined for you in pink, and you can see that we tried to push that isodose line away from the bowel right within this area. The rest of the tumor very well covered by high doses of radiation, but we were cognizant of that as we were putting together his radiation plan. So again, looking at kind of his follow-up scans going forward, on the left, these are both coronal views of his follow-up imaging. The liver is outlined for you in blue on both scans, so the stomach and bowel is in green. Note the very close relationship, again, between the bowel and the liver in the setting. At 3 months post-radiation, you can still maybe make out a little bit of that dumbbell from the original tumor, but no signs of recurrence and maybe some tumor regression. Unfortunately, after that 3-month scan, 10 months later, what you see here is this tumor recurrence right adjacent to the inferior portion of the liver and near the bowel region there as well. So what was happening likely there? As we were pushing our radiation away from the normal bowel, it's likely that we didn't deliver ablative doses of treatment to microscopic disease that we couldn't see in this area. This allowed the tumor to grow back and unfortunately lead to a recurrence for this patient. We look at the same thing in the sagittal view. Again, you can see this intimate relationship between the bowel in green and the liver where the tumor was. And then on the right, you can see this local recurrence that's then seen at the margin of our previous radiation treatment. And so this is something to think about in terms of, well, we were limited in the dose we could give based on our normal tissues within this region. And this led to a recurrence. But normal tissues nearby not can only just lead to recurrence, but they can also lead to toxicity. This is one of our patients with a pancreatic tumor that was locally advanced that we treated with fractionated chemoradiation with gemcitabine. And I've outlined for you here, this is our target tumor within this region that's outlined in red. The duodenum, also in a pink color, and a significant tumor-to-bowel interface. Now, we gave this patient significant dose of chemoradiation, and actually he had a significant duodenal ulcer and bleed requiring an ICU admission. However, by giving him aggressive treatment, he survived that ICU admission, and he actually survived 2 years after chemoradiation with a locally advanced pancreatic cancer. For those of you that treat locally advanced pancreatic cancer, we can realize that's actually a very long time for this patient population. But the nearby organs within this region led to a toxicity for this patient. So what we're getting to is that normal organs near the tumor may limit dose and may contribute to recurrence, in the example of that liver that I gave, or toxicity in this pancreatic patient. So what can we do about normal organs near the target due to location, tumor motion, or normal organ motion? One of the things we can think about doing is real-time adaptation of radiation based on the daily position of these organs and the tumor. And so let's talk about what that actually really means a little bit. What is adaptive treatment? Adaptive treatment means changes in the radiation plan to account for the physical or functional changes of a patient's tumor or normal anatomy each day. This provides the opportunity for dose escalation, decreased toxicity, and even improved accuracy for our patients. So let's go over an example of what we really mean by this. So this is a wonderful slide provided by Dr. Mittauer, who's one of our talented physics residents here. What I've outlined for you is our target, which is a pancreatic tumor here in red, and the location of the duodenum in blue. By the patient's fourth treatment, you can see the duodenum has significantly moved on their daily imaging. I think it's seen almost best down here, where the duodenum and sim here in blue and the location to the tumor, and then where the duodenum was relative to that fourth fraction. So there is this significant motion of where the bowel is relative to where we need to treat. And so those same images is there on the left as I outlined the original position of the bowel in blue and fraction 4 in yellow. And I know most people here are not used to looking at dose volume histograms, but what I will have you just take away from this is that the difference to about 0.5 cc's in bowel here in one treatment was 1.4 gray. Now, when we think about what that really means is that if we have a 5 fraction treatment for, say, pancreatic SBRT, a 1.4 fraction difference from every day from a setup, that could lead up to 7 gray of difference, 20% of our dose from organ motion alone in a 35 gray plan. And that's significant. It can lead to significant toxicity for this patient. And so is this isolated, though, to certain patients? Do we see all sort of motion all the time? This is, again, data from ourselves and from WashU in St. Louis. We actually look to assess for our pancreatic patients the distance between the tumor, which is known as our GTV here, and that planing structure, the PTV, to the duodenum each and every day. We use a term called Hausdorff, but it's basically a measure of distance between these structures for each individual fraction. And what you can basically see here by this box plot, patient 3 has a lot of motion that you see between each individual fraction. This is in centimeters on the Y scale here with each treatment. But patient 2, patient 4, minimal. So it becomes that there's not one standard that there's lots of motion or that there's a little bit of motion. It's individualized for each patient. And so the assessment of the daily change in organ to target distance can allow for an adaptation. And the visualization provided by MRI-guided treatment gives us that opportunity. So what does this actually mean to adapt treatment? So let's walk through a little bit about what that means practically with our V-Ray machine. We would get a daily MRI, as we normally do for a patient undergoing radiation. We'd actually localize a tumor. The physician would actually come by and actually recontour the structures. It means we're going to outline the bowel again. We're going to outline the tumor again and kind of get all the anatomy of the day completely colored in, as we just color in radiation oncology for a lot of our day. And what we're going to do is predict and evaluate that original radiation plan that we put together on today's anatomy. And then we're going to look at that and say, hey, this doesn't look so good because the bowel's in a new position or the tumor's in a new position. We can then re-optimize our radiation for today's scans. And so if you remember early on in the talk, I mentioned the importance of, and I didn't want to go too much into the physics, of that fast treatment planning algorithm. Well, this is where it really comes into play. By being able to recalculate dose quickly, we're able to re-optimize for today's anatomy in a very fast way for patients. After we're able to put together a new plan based on today's anatomy, we can reevaluate that as well, export it for quality assurance purposes, and then deliver it for our patients, all while they're still on the table. Well, this sounds great and wonderful, but can we actually do this in real life? And does it actually make a difference? And so Our colleagues at WashU actually did a theoretical study looking at this for 10 patients with oligometastatic disease, either in the thorax or the abdomen. They replanned them to 50 gray in 5 fractions to this area. These were areas where motion was, they thought, going to be significant. The types of tumors and their positions are on the right of the screen here. And what they did was that they took these plans and took them to no daily adaptation, just applying their original radiation plan to each fraction for the first 3 fractions, or did a daily adaptation for these plans as well. So 30 fractions in total, 3 fractions for each 10 patient. And they were interested in analyzing the coverage of the tumor and the dose to some normal organs as well. So this is some of the data that they found. They found that the application of the radiation plan to the anatomy of the day caused OAR, which stands for Organ at Risk Constraint Violations, in 19 out of their 30 plans. You can see some of them here, trachea, esophagus, stomach, duodenum, small bowel. This graph shows when they exceeded that constraint. Those were shown in red. Those when they just meted their maximum constraint, and those when the fractions just met their constraint. So there was no adaptation here in this part of the study. This was just looking at taking their original radiation plan and applying it to their anatomy of that day. This is an example of what this looks like. This is a patient who had their original radiation plan on the left of their screen. You can see the duodenum in green, and the tumor is there in blue, covered by their isodose lines. They took that plan and applied it to their anatomy of the day. And you can see the duodenum there in green with the arrow nearby has significantly more isodose line coverage. The tumor is actually not well covered at all anymore. You can see that this, on the right of your screen, this area of tumor is not being covered by these high-dose isodose lines. And more importantly, the duodenal dose constraint was beyond what they had planned for based on their daily anatomy, which could lead to significant toxicity for this patient. So what they did was, again, the next part of their study was to take that original plan and then do an adaptation of it using that same outline that I gave you in terms of steps. And what you can see here is that the duodenum that was covered by a lot of this high-dose isodose line, this is the 40 gray line. If you remember before when I showed our study, we were trying to keep the 30 gray isodose line off of there. Is actually pushed back off of the duodenum, and that tumor area that was undercovered is actually much well covered by our radiation here on the slide. So for their adaptive plan, by adapting treatment in these 30 fractions, they improved tumor coverage, known as the PTV, in 21 out of the 30 fractions that they had. And most importantly to me, from a toxicity point of view, 0 out of the 30 adaptive plans had organ at risk violations. You remember that I just showed you, without doing adaptation, the majority of patients had organ at risk violations. So why aren't we doing this? What are some of the obstacles in terms of doing plan adaptation? Is it worth it? And so the total process takes anywhere from 15 to 20 minutes, and some patients are going to have trouble tolerating that. You mentioned you're in the room for 40 to 60 minutes in total, so that can be a concern for some patients. It requires the physicians and the physics staff, who are fantastic and make us look really good, to also be there and really make these plans happen in real time. Though I would strongly argue that regardless of these obstacles, it's really important because it allows for this personalization of treatment for each day. It's really a form of precision medicine. It's just like for a medical oncologist in a room, you have a patient with a BRAF mutation, you're thinking about giving venurafenib. This is another form of precision medicine for our patients, but instead of a mutation, we're really being precise in their anatomy in terms of how we're delivering this sort of treatment moving forward. So this adaptation also helps make sure that we don't miss. This is a patient with a gastric malt lymphoma that I treated and had an MRI sim that showed a position of the stomach. He's a physician, very reliable. For these, we usually ask people not to come in and eat 3 hours before. And you can see from one day where his stomach was to his 9th fraction, there's been significant motion. The stomach is in a completely different position, almost 5 centimeters of motion, in fact. And so this adaptation, by actually analyzing this each day, also makes sure we don't miss in terms of delivering our treatment. And so again, a figure from Dr. Mytower is his original radiation plans on the left of your screen, and we were able to adapt his plan to make sure that we didn't miss hitting the tumor in his stomach for this gastric malt. So as I mentioned early on about what adaptation is, it's taking into account the physical or functional changes of a patient's tumor or anatomy each day. The idea is to allow for opportunities for dose escalation, decrease toxicity, and improve accuracy. So we want to take advantage of that. And so with that, we're thinking about trying to deliver more dose to patients to maybe lead to better outcomes. Now, is that always true, though? And for some patients we know that have liver metastasis, going back to our failures, is that the majority of patients, less than 30% of them, actually have resectable tumors. We like to dose escalate these patients because we know that as we dose escalate, we have improved local control. But we're often usually limited by toxicity. And this is seen on the right of your screen. This is a study by Rule et al. And the blue line here is our 30 gray isodose, the 30 gray that we're delivering to tumor. Our yellow is 50 gray, and green is 60 gray. And this is about local control with liver SBRT. But we're not usually able to deliver this sort of dose to tumors because of normal anatomy and motion. And so by adapting treatment, this may allow us to dose escalate to potentially improve outcomes for patients. And so with that, we've been developing a dose escalation phase 1, phase 2 study here at University of Wisconsin. The very talented PGY1, actually, Jacob Witt, who's going to be joining us here in July, has been working with this with me. We're going to be looking at primary liver tumors or METs that are undergo liver SBRT. We're actually going to start with 50 gray in 5 fractions and do daily adaptation to actually increase to normal organ constraint. So we're going to push using that adaptation based on a constraint rather than just going to dose levels associated with this. So some examples would be, say, bowel constraints, which you see on the left of your screen. We'll start at that V30 less than 0.5 and give as much dose to the tumor as we can while respecting that constraint. We don't see any toxicity, we'll go up to the next level. And we'll keep going until either our toxicity is reached or a maximum constraint is reached that we don't feel comfortable beyond. And then we'll move to treating those patients up at that constraint with as max tolerated dose as we can. And by doing that, we basically are able to adapt our treatment for each individual patient's anatomy, tumor, and it's another form to me of precision medicine, as I mentioned. Now, our ability to adapt treatment is only possible because we're able to see it so much better now with MRI-guided treatment. And to me, it's really seeing is believing. On the left of your screen is a typical cone beam CT that we used to see when setting up patients. On the right is our MRI-guided treatment, how much better you can see it. As we can see the tumor during treatment, this presents all sorts of new opportunities, not only about setting patients up every day, but we can actually see the response of the tumor during radiation or chemoradiation. So that opens new windows for us to look at. And we first noticed this in some of our esophageal cancer patients. And so we've outlined the tumor here in red. On the left is the start of treatment in the axial and coronal planes. And this patient was undergoing chemoradiation. And what you can see is that there's been a significant tumor regression just only 3 weeks into treatment associated with this. This is surprising. We weren't expecting to be able to visualize this sort of regression early on for these tumors. And so we started to think to ourselves, does the regression of these tumors then predict for outcomes for our patients? And so one of our very talented fellows, Bindu, who trained actually at Leeds Hospital in London, and Sunnybrook, who's been with us for a few months, has been working with me to go back and actually contour some of and look at changes in measurements in tumors during chemoradiation on ViewRay. Unfortunately, Bindu couldn't be here today. But what we noticed is that we see some of the biggest changes in our tumor volume in the first 1 to 2 weeks of chemoradiation. And so with that, some alarm bells start going off about, well, can we use this early change to then think about escalating treatment, de-escalating treatment, predicting for outcomes, similar to the way we think about PET CTs and, say, lymphoma. And so because we were not able to usually visualize tumors as well in the past, this opens a whole new door of things to look at. We're not the first ones to think about this, both in the GI tract, both from a esophageal and a rectal point of view. This is a study by Jacobs et al., and they got 4 diagnostic MRI scans, 1 before chemoradiation, 1 during the 2nd to 3rd week, and 2 after chemoradiation before going on to surgery for rectal cancer. And what they found was that the change in their diagnostic MRI via the change in the ADC actually predicted for their pathological complete response, pathological tumor regression, the Mandard criteria for tumor regression here and here. So comparing this early change in MRI actually predicted for pathological response. The only difference now is with ViewRay, we actually get an MRI every day. And so this opens a lot of doors about thinking about how we can use this sort of imaging technology to help predict for outcomes for our patients. So as I mentioned, The change in tumor size or activity during treatment correlates with outcomes in some cancers, as I just gave you the example of rectal. But again, I go back to PET scans where we think about activity after, say, chemotherapy correlating with outcomes. The daily MRI presents a new opportunity for tissue delineation that may allow visualization of tumor response we never could see before, because we didn't have the ability to see this sort of tumor response during treatment. We're going to hopefully try and correlate this early tumor response with some outcomes. And again, this may allow us to determine when to escalate or even de-escalate some of our treatments going forward. So again, with Bindu, who's our very talented fellow, and Ali, who's also one of our PGY1s, who's actually currently here at UW, we're developing a few other more registry-based trials looking at local esophageal or rectal cancer, using daily MRI imaging combined with, say, FLT PET and some other biological markers such as circulating DNA or circulating tumor cells to see if we can come up with a composite to try to predict how patients are going to do in terms of pathological response. Then using that to then guide treatment escalation, de-escalation, those who maybe don't need surgery, those who are going to definitely need surgery. It opens a lot of doors to areas that we couldn't explore before. We also know that with V-Ray, there's some new imaging sequences that are coming up, known as diffusion-weighted, which may also give us some insight into tumor response and behavior, which are very exciting. Now, for those of you who have some physics background, know that our current technology is cobalt-based, and so what that does is it does limit the conformality of some of our radiation plans, and we're expecting our the MR-Linac to be available in the clinics by 2018, which is very exciting. And so we're going to be excited to bring that into UW in the future. The assessment of tumor response during radiation may allow us to personalize cancer treatment, and another exciting future direction of this technology. In summary, MRI-guided radiation allows us to account for organ and normal tissue motion, as I hope I showed you. MRI-guided liver SBRT has similar local control rates compared to the literature, with minimal toxicity, but also provides that new direction of adaptation and potential escalation that we went over. Visualizing the tumor allows us to ensure we are hitting our target and the ability to adapt treatment. And treatment adaptation and the assessment of tumor response are exciting areas of image-guided radiation, and is another form of precision medicine we need to be incorporating for our patients moving forward. There are so many people to thank that it would take me all day to go through everybody, but of course I want to thank the leadership in the department, Dr. Harari, Dr. Bradley from the residency program, Dr. Bassetti and Dr. Kimple, who really provide a lot of research guidance to me, the physics staff, Dr. Brayuth, Dr. Budot, who are just fantastic. We have some great radiation oncology and physics residents who are just wonderful to work with, and our collaborators at WashU and UCLA, and of course our wonderful fellow Bindu, who's also been instrumental for many of these projects. And I'll be happy to take any questions.